All right. Good morning, everyone. You guys are in the fun session. Everyone else, I don't know what they're thinking. So I'm actually glad we kind of have a tight-knit group. When Sarah and I were talking about the session and we were talking about slides for it, one of the comments that went back and forth was making sure we limit the lecture portion of things and really make sure this is a conversation. This is meant to be very informal. You can interrupt, you can ask questions, you can comment, you can criticize, you can heckle. Oh, I'll be heckling. And so I do have to say, so Sarah and I were sending slides back and forth, and I was tempted, and I didn't do it. We were working on the title slide, and I was going to make the CHOP logo like really small and do a big UT just to see if she said anything, but we decided for equal billing between our institutions. I'm really glad to be doing this with Sarah Hopkins from Philadelphia and give you a sense of what we're learning. So we're going to go back and forth with the introduction, and this is just a few slides to set the stage for the conversation to make sure we're all speaking the same language in terms of the issues we're dealing with when it comes to acute flaccid myelitis. And I lied. I lied and it didn't work. There goes, I already lost one. But I'll buy you lunch. I'll meet you at the buffet. All right. So one of the questions we get all the time is, what is acute flaccid myelitis in the context of transverse myelitis? So I wanted to start off by just putting the semantics in perspective and why there's so much confusion around things. So everybody has a central nervous system. It's got the brain and it's got the spinal cord. And the spinal cord, just like in the brain, let's see if this is, I guess it helps to turn it on. So the spinal cord, or not, here it is, has an inner part and an outer part. The inner part we refer to as the gray matter, the outer part as the white matter, and they have different functions. When we're looking at the spinal cord, if we talk about just movement, not sensation, just movement, the way you get your leg to move is to activate a part of your brain. A signal goes down a wire in the spinal cord. It connects with a second wire in the spinal cord, and that wire goes out to the muscle, innervating a group of fibers within the muscle to get movement. So one lower motor neuron, so here's your vocabulary lesson for the day. The lower motor neuron is this wire number 2. One lower motor neuron will innervate multiple fibers within one muscle. So a muscle has lots of different lower motor neurons going to it. So you have to get them all to activate in order to get different versions of contraction. If we take a slice of the spinal cord and we look at it as if we were looking down a pipe and we're looking at it in its length, the outside is the white matter and this butterfly shape is the gray matter. This lower motor neuron, the very beginning of it, what's called the cell body, the supercomputer part of it, lives right here. So it lives in the front gray matter, what's called the anterior horn of the spinal cord. What's in the white matter are all of the wire number 1s connecting down to that wire number 2. So this is like, has anybody wired their home with a central stereo and then speakers in different rooms? You know, you got speakers in the dining room, speakers in the kitchen. I keep wanting to do this. I've never done it. Huh? Still paying off the student loans. I can't do it. Can't do it quite yet. So the idea is there are these connected wires, and as you have a wire going from your stereo all the way down, it may connect to the wires that are going to the speakers in the dining room. It may go down a little further and then connect to the wires to go to the kitchen. And all of these connections are there to get your signals from the brain ultimately down to the muscle. So if we just look at the spinal cord like this anatomy, the white matter versus the gray matter, sounds like an academically interesting thing to pay attention to and time for us to geek out as neurologists and talk about the different biology. It's actually incredibly important in terms of what happens to you as individuals. So I'm going to give you a little roadmap to the spinal cord. So if you were brand new to a neighborhood, you'd take out your GPS and figure out where everything was, where's the grocery store, where are the dry cleaners. I'm going to give you your GPS for the spinal cord, your roadmap. What's in red here are the sensory connections, the wires that are taking sensory information from your body up to your brain. So when you go and you step on a tack, and then you start cursing after stepping on the tack, that signal made it to your brain via these pathways up in the front. So if I were to cut out these pathways, when you step on a tack, you wouldn't feel it. So you need that connection to get the signal to your brain. These pathways in the back are different types of sensation, vibration, and having a sense of where your limbs are in space. So that if you lose the back part of the spinal cord, if you close your eyes, you can't feel the ground underneath you. You're kind of just a floating head. You don't have a sense of where the world is. So these red areas are all sensory, and hence, if you damage those areas, you lose sensation in some part of the body. Now compare that to these side parts of the spinal cord. Those are the wire number ones. Those are the wires coming down from the brain, ultimately to connect with a wire number two to trigger muscle movement. So there is not sensory information over here. So if I were to cut out this part of the spinal cord, you would have weakness. You would have motor issues, but your sensation would be okay. And then here, which we already referenced, the anterior horns are where the very beginning of that lower motor neuron is. This is where the cell body is of the wire that's going to go out to the muscle. So there is a connection from the upper to the lower motor neuron. I think of this pathway over here, this tract, as like a descending elevator in a very tall building. So it starts off at the top and it's full with 100 people. And it goes down a floor at a time and somebody gets off. So at the very top, everybody controlling your shoulders, get off. And then you go lower in the neck, everybody controlling your elbows, get off. And then it keeps going down, controlling your trunk, controlling your hips, controlling your legs. And at the very bottom of the spinal cord, everybody controlling your pinky toe, get off. And it connects to the wire number two, which is going to go to the muscle. Okay? So if I damage this wire number two right there in the spinal cord, if I take a laser and I go to the middle part of your spinal cord and I just cut that out, you will have symptoms in muscles that were supplied by that wire number two. You will not have any symptoms above or below that level. If, however, I go into your spinal cord and I damage this area, from that point down, you're going to have symptoms because I took out all of the people in the elevator who were going down to your trunk or your legs or wherever the case may be. So depending on what part of the spinal cord gets damaged, you get different patterns of symptoms. So if somebody comes in and they have both sensory symptoms and motor symptoms, it is a strong indicator, it's not perfect, but that you are getting parts of the white matter and not just the gray matter. So the way I was taught transverse myelitis was that it was a white matter disease, that it affected the outside of the cord. It was not a gray matter disease the way the textbooks told me. So when I was evaluating a patient with transverse myelitis, I was looking for evidence of damage to these sensory fibers, damage to these sensory fibers, or damage to those motor fibers. And there was a very specific pattern I would look for, a specific pattern of weakness, a specific pattern of sensory loss. What we have learned with acute flaccid myelitis is the classic description was wrong. You can have inflammation in the spinal cord of different patterns. In acute flaccid myelitis, which we consider a variant of transverse myelitis, because all we mean by the term myelitis is there's inflammation in the cord. That's all it means. So there are lots of ways to get it and lots of places in the cord you can affect. So in acute flaccid myelitis, the predominant target of damage is here in those anterior horns, but as you'll hear about from the experiences at CHOP and nationally, there are variable amounts of damage affecting either the sensory tracts or these motor tracts off to the side of the cord. So we'll have some, predominantly children, although we have had some adults, come in with just evidence that their gray matter was damaged. Very pure, we don't find any evidence of white matter damage. In our hands, that's actually relatively rare. The majority of our kids have had mixed damage, with the predominant being at the gray matter, and then some degree of inflammation affecting the white matter. And we're going to talk about why we think that's important from a treatment and a rehabilitation and a practical point of view. It turns out that the type of weakness you get when you damage this part of the spinal cord versus this part of the spinal cord is different. So when I damage wire number 2, there is no signal going to the muscle. So it gets floppy and loose because it's got no stimulus to contract. When I damage wire number 1, but I leave this intact, then the muscle still has a connection to the nervous system. It still has wire number 2 there, but there's no parental supervision happening over wire number 2. And so it just takes on a life of its own, and the muscle gets tight. And so the difference between a loose muscle or a tight muscle is, do you have wire number 2 intact? So we will have some individuals with acute flaccid myelitis, and they come in and they have floppy arms but tight legs. So they damaged in the cervical cord wire number 2 going to the arms, but they damaged in the cervical cord wire number 1, which was ultimately going to control the legs. So their legs get tight, but their arms stay loose. So when we do a physical exam and when we look at adults and kids with transverse myelitis, we are trying to sort out, at any given level of the cord, how much of wire number 1 is intact, how much of wire number 2 is intact, because it's different symptoms. Yeah?
Wire number 2, can you, I forgot what it stands for, but can you tell that that's damage from an EMG?
Yeah, so a nerve conduction study, or EMG, is, so some of you or your children may have had this, where we either put patches on the skin, we give a little electrical shock and we see how quickly the signal goes, or we put a needle in muscle and we see when stimulating it or moving it how the muscle contracts. Those tests are looking at the fidelity, the health of wire number 2. Okay? So what would we expect changes on that if we only damage wire number 1? In general, no. There are actually some subtle things that change with spasticity. But in terms of, we can't quantify the health of wire number 1 by doing the nerve conduction study or EMG. We can do something called a somatosensory evoked potential, where we place electrodes on the hands or the feet and then up the back and the head, and we stimulate the sensory fibers, and we see how quickly does it take a signal to get from your big toe to your brain. So that's not motor, that's looking at, are the sensory fibers intact? All right, so I'm going to turn things over. So that's just the introduction in terms of the anatomy and how it relates to what we see clinically. We're going to shift gears a little bit and give you a sense of what's been happening in acute flaccid myelitis. And then as we get to the end and talking about rehabilitation, all of this is going to come back. But the point of these slides is just to set the stage of the confusion that has existed semantically between these terms, acute flaccid myelitis and transverse myelitis. All right, yes? Both, yeah. So there are some, not all MRIs are created equal, and I think Sarah will talk about this. Timing of MRI makes a difference. So we have a lot of kiddos who they come in and the initial MRI looks normal, and everyone's saying, well, you know, what's this? And then if you repeat an MRI later, you can see the abnormalities. And so I trust my clinical exam, and the MRI is there to confirm what I suspect. And it's also to keep me honest to make sure I didn't miss anything on my clinical exam. So both are important. We just have to remember neither is perfect, neither the human or the technology. So, other questions about this? All right, Sarah, you're up. You decide how you want to handle it.
All right. Thanks. All right, we'll see how this does. I'm definitely using the elevator analogy.
Yes, you did. That was like sort of 2002.
No, it's before our time.
We can do cast later.
Okay, so wanted to talk a little bit about typical presentation of acute flaccid myelitis, and this is basically the two columns. So actually, the column the furthest on the right is our data from CHOP. Actually, it should be one more as of a week ago, but you can see the median age basically in 2014. So the Colorado and CDC data are from 2014. Colorado was 11 and a half. all of the CDC data from 2014, the median age was 7.1. And then we noticed that kids in general, at CHOP and more even in 2016, were younger. All of our patients at CHOP and all of the patients in Colorado, and most of those reported to CDC, had a preceding illness. As a matter of fact, all of our patients were febrile when they came in, which can happen in transverse myelitis for sure, but was different that this was 100% of our kids. A lot of the patients also present with a headache and a stiff neck. Of course, many of our patients were too young to tell us. And also there's pain in the affected limb often. Not many patients had altered mental status. And overall, there may be some more upper extremity involvement. One reason for that is that it seems like AFM in particular has a predilection for the cervical cord, primarily from C2 to about C7. So what we tend to see is that it's weakness more in the shoulder, and then as you go out towards the hand, the movement tends to be more preserved. For instance, now I have patients who, even though they still have a lot of weakness from their initial episode of AFM, they may be able to write, and most of them are back in school and doing just fine. Cranial nerve involvement has been, I think, something that's really interesting because there does seem to be a little bit of a geographic difference. For sure, Colorado saw it in almost all of their patients. But at CHOP, even though I know for sure firsthand that we've looked for cranial nerve involvement in our patients, only one of our patients has had it. One thing that I think is really important moving forward as we talk about acute flaccid myelitis and as we talk about what the potential causes are and how we're going to work through things over time as neurologists and working with the CDC, is to keep in mind that acute flaccid myelitis is something that is very often missed on initial evaluation. I've had patients who came to an emergency room and were diagnosed with toxic synovitis, which is a problem with a joint in the arm. I just saw a patient in August who was diagnosed in July with something called nursemaid's elbow, which is kind of an injury where the elbow gets dislocated, and somehow it was missed that he was febrile and wasn't really moving the arm even after they kind of reduced that injury. So it's something that is very often missed in an initial ER or even pediatrician visit. And it's really important because sometimes once you start to get weakness in an arm, that can progress and spread actually area-wise in the spinal cord, but also up into the brainstem, and that can affect breathing. So that's the most important thing, I think, really, for me, is that I'm afraid that some of these kids are going to not be recognized, and then they're not going to get the supportive care they need. Oops. All right, so this is a slide that's from the CDC website. It looks at cases of AFM from August of 2014 through December of 2016. So in 2014, there were a total now of 120 confirmed cases, and in 2016, I think we're up to 145 or 146. Definitely nothing going on in, minimal going on in 2015. Yes?
Since there's so much in 14, is that when that Enterovirus D68 came out?
Yep, you got the next thing out of my mouth. So, no, perfect. So, one thing that's interesting about this is that in 2014, we know that that increase in cases occurred in the setting of an outbreak of severe respiratory infections caused by Enterovirus D68, which is an enterovirus that causes cold-like symptoms and is actually very similar to a rhinovirus or a common cold virus. So we know for sure that was potentially the issue in 2014. So in 2015, there weren't as many severe respiratory illnesses with that virus. You know, it's always floating around a little bit, but definitely not an outbreak. And then in 2016, the thing that clouds the picture a little bit is that we saw another bump in AFM, but we really didn't see a bump in severe respiratory illnesses with Enterovirus D68. So that clouds the epidemiological picture there a little bit. So backing up a little bit to 2014, though, in late 2014, early 2015, we were asked to be involved in a project with the CDC, because what they said was, we know we have all these cases in 2014, and neurologists are telling us it's different, but we need to see the evidence that this is something different. So what we did is we went back, we requested MRI reports for anybody with a diagnosis of transversemyelitis or MS or spinal cord infarction, anything that could be that AFM could be mistaken for or diagnosed as. And then we also searched the MRI reports by text for things that we thought could be associated with transversemyelitis, you know, increased T2 in the white matter, things like that. And what we found was that AFM was definitely not entirely new. It was something that we'd seen a little bit of before, up to 2 cases a year. But in 2014, things were definitely different, and in 2014, things were clearly different. And in terms of what we know about Enterovirus D68 circulating at those years, we know for sure that there was more of it in 2009. But that's the only past year that I'm sure of. So in terms of the connection, yes? That's okay. So there are, I was going to say, let me see how much I talk about it. So I think it is coming up. That's okay. So I'm having trouble remembering for sure because these are a conglomeration of some other presentations, and then I took some things out. So, but I promise we will get to that even if it's not there. So Enterovirus D68 was first really noticed in California in 1962. As I mentioned, initially classified as a rhinovirus. It is different from other enteroviruses in that it's primarily spread by respiratory secretions. And actually, in some of the respiratory PCR panels that we routinely do in kids that have upper respiratory infections, it can actually show up as a rhinovirus. So when we see rhinovirus, we're suspicious that it could be this. We know it does cause severe respiratory illness, especially in patients with asthma. So in terms of asking whether it's the cause of AFM, so definitely the timing of that 2014 cluster was pretty compelling. There were over 1,150 cases of Enterovirus D68 respiratory illness in the US that year that were reported, and we suspect that there were really a lot more, right? Because most of the kids that just had a cold, nobody's calling CDC about those. And the other thing is that when we really were careful in 2016, we were very careful about if we saw a child, we suspected they had AFM, within 24 hours, we were testing for enterovirus in the respiratory secretions, in the serum, in the stool, in the urine, and in the CSF. When we did it that way, we found that 7 of the 7 patients that we tested in 2016 did have Enterovirus D68 PCR positive in the respiratory secretions. Now the problem is that when we're looking for enterovirus, we are typically able to find it in the first few days. So it's pretty easy to find it in the first 3 days, maybe even out today 5 or 6. You can still find it, but then after that, that yield really drops off. So if it's not thought of pretty quickly, you may not get that, you may not actually find the link. Does that answer your question?
Yes, so there was a marker for that. So, or whatever, if they tested for that.
If they tested specifically for an enterovirus PCR and the sample was sent to CDC and all of that was negative, provided provided, I mean, there are some caveats here. Unfortunately, there are some caveats for any testing. So the first thing is that it was done close enough to symptom onset. The second thing is potentially how that specimen was handled or how long it sat around. And then the third thing is who ran the test, what the laboratory was, you know, and it's also not 100% anyway.
Where it was sent from.
Right, yeah, but it is not necessarily as easy as you would think to collect respiratory secretions from a young child. So, anything to add about that?
Yeah, so what I said, the analogy I use is, you know, if you come in and you see police wires, broken wires in your home, and you say, geez, I wonder if rats are chewing on the wires, there's 3 levels of evidence. You can either come in and see the rat chewing your wire, often has that really happened. You can see it chew wire, and then later see rats running around the house. Sometimes that makes the light bulb click. Or you can see it chew wire and see rat dropping somewhere and say, geez, was there a rat here at some point? And so the whole argument that's been going on at a public health level is, with very rare exception, we've never seen the rat virus chewing on the wire live. We've had people where we've had the damage and we found the rat in the nasal wash and said, geez, they got the virus and chewed wires. What are the odds? And it's a statistical position. And then to your point, what if the rats are gone? We never find evidence that they were rat dropping. They were there to begin with. And that assay is not fully developed. We're still trying to sort out. It's an antibody test, and the data we saw from the CDC is odd at this point, and so we're still trying to make sense of it. So if somebody asks years later, was there a virus here at some point, we're still trying to perfect that technology.
And just from, after I started researching everything, that seemed to be the case. But in the end, I just want to know why. I mean, it doesn't matter.
Right. No, I know what you mean.
It helps me to kind of have something, because everything's idiopathic.
Right. So, and I think two additional things. So the first thing to know is that the older you get, the more likely you are to be positive in terms of antibodies for this virus anyway. So that clouds the picture. Almost everybody walking around has antibodies to this virus, at least in the U.S., we think. And then the other thing is the inability to find it in the spinal fluid. So that's happened with some other things in the past. Polio in particular was a little bit harder to find in the spinal fluid than some other viruses have been.
The 3 to 5 days, that's post illness onset, not the paralysis.
So that is post-illness onset.
Well, in this cohort, it was post-presentation with paralysis. Okay, so the percent positivity, because in this cohort they were coming in for paralysis and they were swabbed. If you look during the respiratory outbreak, so kids who were going to ICUs in 2014 with respiratory distress, who were getting swabbed, the percent positivity was higher per sample than what's happening. So when we get one of these viruses, so there's been studies on rhinoviruses and
And it's also important to note that there are other viruses that have been proven to cause AFM. You know, the classic one that everybody knows about is West Nile virus, the clinical picture with West Nile, and what we're seeing now is the same. Though most of these patients have been tested for West Nile and have been negative. All of my patients have been tested for West Nile and were negative. And then Coxsackie virus, so hand, foot, and mouth can sometimes cause this. So it's really hard to pin it down because some of these other things are circulating as well. And it's important to remember that sometimes I'll hear people say that, oh, you know, I thought this patient had AFM, but the Enterovirus PCR was negative. Enterovirus PCR is in no way a diagnostic test for AFM. So a little bit more data here. Another thing that they did in Colorado based on their 2014 patients was that they had respiratory samples that had been collected for other things. So just the regular routine respiratory PCR samples that we collect in our patients with respiratory illness, and also samples from patients who'd been tested for whooping cough. And then there are 11 CDC-confirmed cases of AFM from 2014. So when they found that when they looked at their AFM cases versus the respiratory PCR patients, which is this middle column, and then compared to their whooping cough, this is Bordetella pertussis, they found that their patients were the black is Enterovirus D68, so they found that their patients with AFM were much more likely to have tested positive for Enterovirus D68 than the other two groups. So the odds of having Enterovirus D68 in the sample were about 10 times higher for the AFM cases as compared to, they were 4 to 10 times higher for the AFM cases compared to the other two groups. Which actually does seem, I like that study. I think it was a nice, clear project. So then the other thing is that there is this mouse model. I don't know if you guys have heard much about that. So Ken Tyler and his group in Colorado found that if they took the Enterovirus D68 strains from the 2014 outbreak, 4 or 5 of these strains induced paralysis in mice when injected intracerebrally, and that some mice would develop it even if they gave the virus intranasally. And this is what the mice look like. Hoping my link works. Maybe. So they found that Enterovirus D68 could be isolated from the cords of the infected mice, and then that virus that they isolated from the cords of the affected mice could be used to infect other mice. All right. Apparently it's not gonna. It might be. Let's see. I've been pressing it. It just hasn't been going. Oh, it wants me to connect to the internet. All right, well, I will do that. We'll see how good this complementary standard internet access really is. Yeah, really.
I was just going to say that's your.
If you go to the Hilton meetings one.
Oh, that's true. I should have done that. I was going to say, there is not a party in my room tonight. All right. Now the question is, can I get it back? All right. Okay, last time. We'll move on if this doesn't work. it good enough for video? There is a video in here.
There's a link on the top left. If you keep scrolling up, and it'll bring the supplementary.
Thank you.
We're now there, supporting information.
There we go. Thank you. There we go. I knew I'd found it before. Thank you. All right, you can see this mouse's left forelimb. Let me get it back up here. Left forelimb has flaccid paralysis that is really almost exactly the same as what we see in our patients. It's he can't move kind of this area at the shoulder at all. And when they did look at the spinal cords of these mice, they found that there was death of the motor neurons. Interestingly, one thing that they also did was take antibody against Enterovirus D68, and they found that when they did give that to the mice, giving them the antibodies did prevent the development of the disease. If it was given really, really early, those mice didn't get paralysis. In terms of treatments, this is really, I think, one of the most challenging things given the state of the data at this point. So there are no symptomatic studies. You know, really, when we had an increase in patients in 2014, it was something that was relatively new. And you know, frankly, I think most of us were hoping we weren't going to see another outbreak exactly like that again. There have been now multiple case reports in series that have found not necessarily a clear improvement with treatments commonly used for transverse myelitis, although we do empirically use these treatments for some patients with AFM. Given the mouse data, which granted is in mice and not in people, there is, we think, some role for giving IVIG, so antibodies, which we know does include antibodies to Enterovirus D68, at least the circulating strains that were there in 2014. We have tried using that early in the disease. Some people, I know Dr. Greenberg has had some patients where he felt like steroids were helpful or plasma exchange even was helpful. Our experience has been that that hasn't really been particularly helpful at all in the patients that we've used it in at CHOP, which actually may even mean that there are some differences between the patients that we're seeing at different centers with AFM, or that there is perhaps there's some difference in the people that get AFM. You know, maybe there are different individual susceptibilities there. The other thing we have considered is using fluoxetine, which is Prozac. You know, which seems completely out of the blue. And the reason for that is that there was a study out of CDC, I believe, where they looked at all kinds of different substances in vitro, so just in the lab, not in people, to see if they would inhibit the growth or interfere with the replication of Enterovirus D68. And Prozac was the only thing that's already FDA approved to potentially use kind of in acute flaccid myelitis. So there are some of us that tried it in our 2016 patients, you know, after reviewing with the families, you know, potential risks, which are really quite minimal. And I can't say that anecdotally we saw improvement in our patients at CHOP, but there is a group trying to get together to kind of collate our data from 2016 and see what was going on there. So outcomes,
That's within the first couple of days to do the Prozac 2 or later?
so ideally, you know, if you think it's an infection, which I think most of us do, think at least there's infection in the story of AFM somewhere, then you would want to address that as quickly as possible. So prognosis is guarded. In the case reports, we find that most people say that the patients that have had it do regain some strength over time, but most do not completely recover. And our experience has been that the extremity that's most involved generally seems to be the least likely to recover. I don't know if you've experienced the same thing. And may in fact remain kind of flaccid for years in the future. There are some studies starting to look at how do we predict who's going to be more affected and who's going to be less affected. So there's one study that looks at the amount of gray matter involvement in cross sections and whether that, suggesting that maybe that impacts how well these patients will do. And then there is some data that suggests that severity of changes on the EMG may kind of predict outcome as well. Yes?
Is there a way to tell if it's damage to that cord too, or if there's death? I heard you say death and damage. Is there a way to test?
Right, so you can, EMG can help you figure out how many motor units there are and how kind of intact your anterior horn, your nerve supply is to a particular muscle. But immediately, you know, there's not kind of a way to know for sure how much. But over time, you can also even see changes on the MRI as well, you know. Some patients will have follow-up MRIs and their MRI will become more and more normal over time. I do have a couple of patients where there's been clear significant injury to the anterior horn cells such that you have on the MRI what was previously called an owl's eye sign in cases with polio, where you just have seen actual death of those anterior horn cells, and that's a little space now, kind of in the spinal cord. I would say those kinds of MRI changes are relatively rare. The majority of patients, when you do a scan later, actually it's becoming more normal.
So there's only, I think, 6 more slides, and then it's all conversation. But as you've been doing, continue to ask questions and interrupt. So we're going to talk about the approach to rehabilitation in acute flaccid myelitis, and this is to bring full circle what we started with in terms of the anatomy. And embedded in this is some of what Sarah was referring to in terms of differential responses to different therapies. So one could imagine that how people recover from damage to wire number 1 and how people recover from damage to wire number 2 is going to be different. Why? So when wire number 1 is damaged, so for example, if I have, and I'm going to make up a number, 1 million wires going from my brain down to the bottom of my cord to get my right foot to move, and I take out 200,000 of them, your body has to figure out how to use 800,000 wires to get the job done of 1 million. That's plasticity. That is learning to use what's left to get the same result of what you originally had. If I have damaged wire number 2, it doesn't matter how plastic my brain is, I need other wires to sprout and take control of muscle fibers. Because if the muscle fiber has no connection to the brain, it doesn't matter how your brain tries to adjust, that fiber will not contract. So when there's damage to wire number 2, we are biologically needing sprouting to occur. So if you have 1 million wires going to your right foot muscle, and I take out 500,000, I need the 500,000 remaining to branch out and take over control of the disconnected muscle fibers. Those are 2 completely different biologic processes. There are some commonalities in terms of how we try to promote each of them, but at their core, they're different biologies. And this informs the rehabilitation. And it gets to the point that the rehabilitation depends on where the injury is. So everybody's rehab protocol is going to be a little bit different. So we get asked all the time, Janet gets the question all the time, well, what's the protocol for transverse myelitis? There is not a transverse myelitis protocol or an AFM protocol. You have to evaluate the person to decide which of these high throughput connections were affected, which of the lower motor neurons were affected, because a child who can feel their legs is going to have a different rehabilitation protocol than one who can't. So knowing if sensation is intact or not as best as you can in the real little kiddos, it can sometimes be a little challenging to sort out. But knowing where the issues are dictates a lot of what happens in terms of rehabilitation. So I'm really just going to have one slide on this because I figured this would be a lot of the conversation. So I'm not going to go into details because it is so individualized. I just wanted to present some themes, and I would love input in terms of what themes I'm missing or any additions or criticisms of this. But specifically in acute flaccid myelitis, my personal belief is one of the most important things is to maintain as much muscle bulk as possible. So when a muscle loses its wire number 2 and it's got nothing connecting it to the nervous system, it starts to atrophy. And it starts to atrophy very quickly. It starts to atrophy within days of the injury. And a couple weeks out, we'll go into a hospital room and say, that arm is thinner than it was 2 weeks ago, and it just keeps going from there. What I tell people is, you know, we've got people working on stem cells and science of maintaining and repairing nervous systems, but if you don't have a muscle to connect to, it doesn't matter what I do for the nerve. So anything we can do day one to preserve muscle bulk is extremely important, and part of that we think is using electrical stimulation to try and maintain as much muscle bulk as possible. The second on the list, I call prevention of contractures. I really should expand it to prevention of all complications of immobility. It's not just contractures, but that's, I think, the most obvious and most common one we deal with, but there are others, I think it's fair. We've seen subluxed and dislocated shoulders and joints and all sorts of things, but the issue that tends to prevent functional recovery is if a muscle is not being used, the tendon that attaches that muscle to the bone starts to get firm, hard, and shorter than it should be, and so a joint can get fixed in a location. So what's to say 2 years later that the nerves didn't sprout and the muscles got innervated and plasticity occurred and you could have movement of a hand, but if the tendon has it stuck like this, none of that matters. And so from day one, we are working to prevent contractures, and then on day 365, if contractures are setting in, we are working to reduce or get rid of them. It is never too late to deal with contractures. But every day that goes by, it's making it harder. Screening for complications, there's the acute and the long term. I'll talk about the long term because that's, I think, for this group what we're interested in. Watching for scoliosis, watching bone density, watching for bowel and bladder complications are probably our top 3 that we see other than contractures. I don't know if that's fair in your estimation. There have been conversations about nerve transplants or tendon transfers, and I should list both. There are surgeries that can be performed depending on the timing of the injury relative to the time of presentation to try and bring back function in a limb. And the last 2 is where I want to spend a fair amount of time, and I'm glad that my colleagues from Kennedy Krieger are here because I give them the credit for, frankly, nationally and internationally probably pushing this more than any other institution, and they're right. The role of electrical stimulation relative to recovery. There are lots of theories as to how it works. But in the end, there's good evidence that it works, and it's worth noting not all electrical stimulation is the same. So how you set up the device and how you use it makes a big difference. We get phone calls all the time on we are stimulating a muscle but not getting a contraction. And the first question is, A, should we keep stimulating? And we say yes, because we actually think there are reasons to stimulate beyond just getting a contraction. And the second is, well, what are the settings on the simulator? Because often you have to change the wavelength duration, the amplitude, the morphology, all of it. And again, I have experts in the room in order to get a stimulation. We are hoping to see some new devices come out that use a different setup in terms of the current they deliver to be able to stimulate a denervated muscle, a muscle that doesn't have a nerve attached to it. There are ways to get that muscle to contract, but the devices that are in the US are not readily set up for that. And then the notion of activity-based rehabilitation. This really gets to the notion of plasticity. I have lots of patients who have a strong quadriceps but can't walk. So there is a difference between having strength and having function. And if we're really going to induce recovery, we have to put people through the paces of the activities that we want them to recover. One of the things I remind families about is the human nervous system is not genetically encoded to repair to its prior existence. So there is, once a nervous system is damaged, there is no gene that gets activated to say regrow the nerve. That gene doesn't exist. What does exist is if the biology asks the nervous system to repair, then it can. So in the clinic, I say the only language the nervous system speaks is rehabilitation activity. It doesn't speak English. It doesn't speak prayer. It doesn't speak hope. So if you want to communicate with your nervous system, you know, patients can lay in bed all day long and try and get arms or legs to move and talk to their limbs. It's as if you're in Greece and you don't speak Greek. If you want to speak the language of your nervous system, you have to do the rehabilitation. That is the language your nervous system speaks. And so if we are trying to get an arm to move, we have to move the arm. We have to get it to move in order for the nervous system to recognize that there's a deficit, and whether it's sprouting of a peripheral nerve or plasticity at the central nervous system, whichever one you need, it's the activity that really drives the recovery, at least in our experience. Research and rehabilitation is the hardest research to do. You could not pay me enough to be a physical medicine rehabilitation researcher. I would just drown my sorrows every night in a bottle. Because, you know, if I'm doing a study, if I'm doing research in HIV and I want to study an antiviral, I get 1,000 people with HIV, I put them on the retroviral, and then I see how many people have no virus at the end of the study. They all had HIV, and we could see all the HIV viruses were genetically the same. If I want to do a study of spinal cord damage from AFM or transversemyelitis, you'd say, well, go get 100 patients with AFM and transversemyelitis and study them. All 100 are completely different. How do I compare somebody who had dominant hand weakness versus non-dominant hand weakness? How do I take a transversemyelitis patient who's at T5 versus C3? Do I lump them all together? How do I do somebody who had bowel bladder involvement versus not? Yet they're all in the same pot. So it's very difficult research to do, and yet I keep asking them to do more of it. It's really not an excuse. I'm just saying it's hard. You just got to keep going. All right. So I want to just end the slides putting everything together in terms of what we're dealing with individuals and what we're dealing with as communities. The comment you made in terms of the cause really doesn't matter. Really what I want is for my loved one to walk and be functional. At its core is 100% true. I'll challenge it a little bit to say that the only communities that's going to care about this at a global level are families that have been affected. So if I ask you, are you know, how worried and passionate are you about malaria? You say, well, it sounds like a really bad thing and this, that. And then at lunch today, I'm not thinking about malaria. I mean, it's not driving me. People with malaria are thinking about malaria. So now, if you're the next person to get malaria, you say, well, what the hell have you guys been doing all this time? Come on. I mean, let's pick up the space. So the only group that is going to push for change are individuals who are affected, and I feel there's a power there. And here's where the knowns and the unknowns about this issue are catching up with us. So first thing to recognize is in the United States, so we are one of only a handful of countries in the world that do not mandatory report acute flaccid paralysis. So globally, there is surveillance for any child who all of a sudden becomes paralyzed. It has to be reported to the national health system, because they're looking for polio. Well, the United States, years ago, said, well, we have no more polio, so why invest in this? So any child showing up with acute flaccid myelitis does not have to be reported to any agency whatsoever. It is all voluntary, and it is all state by state. The Center for Disease Control requests that cases be reported to state and local health departments. I can tell you from experience, this is ridiculously variable. So the slide that Sarah showed from the CDC numbers with that spike in 2014 and then down in 15 and then up in 16, by definition is an underestimate of what's going on. There is no way around it. We are missing cases. The question is how many cases. And then in order to report, we fill out paperwork. We send in medical records and images. And over the last 2 years, the CDC has been trying, with, I would say, good progress, to professionalize that system of who looks at the images, and Sarah's intimately involved in this, and trying to make sure that we're categorizing children appropriately. But I can't tell you what the incidence and prevalence is. One of the things that's interesting is, if you notice on Sarah's slide, on 2014, the first date here was August. I had cases in May, June, and July, tons of them, that never made it to the numbers because the CDC only opened its reporting in August. I said, well, what about these kids? They said, well, no, we're only taking from August 1. That seems a little arbitrary to me. And so all of the stats that go into this are somewhat artificial. So, causation. And it gets to this notion of, do you catch the rat in the act of chewing on the wire? Do you see him in the same house, or are there just droppings? This is one of the most controversial topics worldwide. The same thing we're seeing in the US is happening in Europe. They had outbreaks in 2014 and 2016, and we are working with them to compare notes, and it is almost identical, what we're seeing epidemiologically. So, how do you prove causation? So, and this comes up all the time. How many people here, either themselves or interacted with families through the Transversemyelitis Association or locally, who suspected that a vaccine caused injury to the spinal cord? Is this a theory people have heard? I hear about it every day. Okay, so how do we prove injury? Some people come in and say, you know, Dr. Greenberg, the week before I had my myelitis, I had a turkey sandwich. Was the turkey sandwich the cause? Could be a virus. Could be it's when we can't catch the rat in the act. How do we prove causation? And so the biggest issue going on from a public health perspective is this virus, Enterovirus D68, for which we have very strong circumstantial evidence to suggest that it is causing a large number, maybe not all, of the cases of acute flaccid myelitis. How do we prove it? Because if we knew that it was the cause from a public health perspective, we may do things differently. If you had asked me, if I had known in 1910 that the polio virus was the cause of these little outbreaks of acute flaccid weakness in the US, and that in the 1940s we were going to see 50,000 kids paralyzed from the virus, I might do things differently in 1910. And so the part of proving causation is about planning ahead and trying to make sure no other families go through what we have been through relative to this illness. When this first popped up, when AFM first popped up and we had a national phone call in the summer of 2014, we were prepping for the phone call, and it was looking so much like polio, but the kids were testing negative for polio. I realized I've never treated acute polio. I've never seen a case of acute polio. That was not in my medical school or anything like that. So I called one of my colleagues who trained in India, and I said, here's what we're seeing. And he says, it sounds like you got polio. And that's what he took care of when he was seeing cases of polio. And so if we knew what we were dealing with or what we were in store for, we would do things differently. So this is now my soapbox. What I'm going to show you is what comes directly from the CDC website. And I'm just going to have you think about it for a second. What they say is, the CDC has tested many different specimens from patients with a wide range of pathogens that can cause acute flaccid myelitis. To date, we have not detected a pathogen, a virus, in the patient's spinal fluid. A pathogen detected in the spinal fluid would be good evidence to indicate the cause of AFM, since this illness affects the spinal cord. I'm going to translate this sentence. They want to see the rat actively chewing on the wire. They say, listen, we want to be able to walk in and see the virus in the spinal fluid. Now, that makes sense to all of us, and it's a very reasonable statement. I would love to catch the virus in the act. Now, I'm going to flip to the next page, the same link on the CDC website. This is just cut and paste. And this is from their polio website. Nobody argues that polio causes poliomyelitis, the polio virus. And they say, you really can't find the polio virus in the spinal fluid of people with polio. We test it over and over and over again. You cannot get polio out of the spinal fluid of a polio virus easily at all. It's actually very rare. Where do we find polio virus in an individual who has polio? In their stool specimen. So internationally, if you think somebody has polio, what do you send the lab for testing? It's not spinal fluid. It's a stool sample. And we catch so if we see the virus in a stool sample, and you come in and you're paralyzed, the CDC says you have poliomyelitis. So there is intrinsically a disconnect here when dealing with new entities on where we set the bar in terms of evidence to prove causation. And so we are going round and round, nationally and internationally, trying to decide what standard we're going to set for causation. My argument is if you look at the circumstantial evidence we have and if you limit it to testing the right way, there is more than a strong case to be made that this virus, the D68 virus, is causing a lot of paralysis in our kids worldwide, something we haven't seen in large numbers before 2014. We saw it, but not in large numbers, and we need to understand why. So we've got several studies going on nationally to try and get at this. The Capture study. Yeah.
So you think it's the virus itself that's causing...
Good question. So I got very interested in this relative to polio because if the virus is directly damaging nervous system tissue, the treatment might be different than if it's the immune system damaging tissue. Okay. So would I expect steroids or plasma exchange to treat a virus? No, I don't. So how do we parse this out? My estimate of what's going on is the virus is directly damaging anterior horns, so that wire number one, but it elicits an immune response that is damaging the rest of the spinal cord. So what we're seeing in our hands, and Sarah is absolutely right, there's differential experience here. So all I can talk about, I can't talk about this authoritatively based on large numbers, although we hope to get there with the Capture study, is if we have kids or adults who had cervical events, so on the MRI and clinically the action was in the neck, but they had symptoms in their legs, the only way to do that is to get wire number one in the neck. Remember that elevator going down, okay? When we have treated those patients with the steroids and plasma exchange, their legs are doing great. So they go from being vent-dependent quadriplegics to walking on their own, but we are still left with arm symptoms because the wire number two didn't get a benefit from the plasma exchange and the steroid. It was the wire number one. Now, is that a good thing? Yes, I mean, salvaging as much as we can is important. And then it transitions into making sure that it is safe. Is it possible that I'm causing more damage to wire number two by allowing a virus to replicate, by treating in this way? And this is initially what the CDC cautioned against. In our experience, we haven't seen that. We haven't seen people decline in front of us as we're treating them. There are case reports of this happening, so this is not universal in terms of somebody declining during treatment, but that's not been our overall experience. Yeah, Janet?
So don't a lot of the MRIs, even with the cervical kids, show enhancement in the psychotic spinal area?
Yeah.
Would that be the direct attack that would cause problems in the lower extremity?
So we've seen a mix. So we've had kids who have enhancement elsewhere and don't. And so we have had kiddos, they tend to be the way younger ones, where it looks like wire number two was affected throughout a lot of the cord. The nice thing about the clinical exam is if we walk into a room and somebody has increased tone in a limb, so they're not floppy, wire number two has to be intact to that muscle. There's no way to get increased tone whatsoever without it. So if I go in and I tap on reflexes and we get kicking, lots of kicking, or we get tight muscles 2 weeks after, 1 week out, we know that the pathology's got to be wire number one with an intact wire number two. So we use both the MRI and the clinical. And so to your point, my theory is there is some damage that is viral mediated and some damage based on the immune response that's elicited. And it's worth noting, this is not a new story. So if you look at the literature for herpes encephalitis, exact same thing. There's damage from the virus, but a lot of damage from the immune response to the virus. Bacterial meningitis. So community-acquired bacterial meningitis, there's a lot of damage from the meningitis. There's a ton of damage from the immune response to the bacteria. The official guidelines in the United States for treating bacterial meningitis, which used to have a 20 to 35% mortality rate associated with people who are dying of bacterial meningitis, the guidelines still state before I give a person antibiotics, I'm supposed to give them a dose of steroid before the antibiotics. Because when I give the antibiotics to a kid with pneumococcal meningitis, as those bacteria are dying, the immune response becomes huge and they get sicker before they get better. And there was about 20% of kids who were losing their hearing. They were becoming deaf from meningitis. If I give the steroids before the antibiotics, the deafness disappears significantly because we blunt that immune response to the bacteria. It's never as easy as just treating a virus or just treating the immune system. We have to take into account both.
Right, and I think it's really going to be important to see data from the Capture study and other larger studies, because I have had the experience of giving steroids to a patient and watching them get worse. However, it's very likely that, I was going to watch them get worse even if I hadn't given them the steroids. But parsing that out based on such a limited number of patients is just really difficult.
Yeah. And so this is where community comes in. There is no single center that's going to sort this out. There is no single entity that's going to sort it out. From a public health and advocacy perspective, we are trying to partner up with families and groups at local, state, and national levels to raise both awareness and resources. Because we do, it was a good name for a study. We do want to capture as many patients' experiences as possible, because that's the only way we're going to sort through this. And so we've got time, as we wanted, for a discussion about people's experiences with AFM. To your point, causation aside, recoveries are different. I'll tell you in our center what we're seeing are steady recoveries. I've got kids now who are 3 years out from the 2014 who are still improving. It's a little bit like watching grass grow for some. It's just very slow and very subtle. And sometimes families aren't even as aware. They'll come and say, oh, things are about the same. I'm like, really? Because he wasn't scratching his nose. I have it in my note. Cannot scratch nose. And now he's scratching his nose. It's very slow. And what I'm telling families is recovery stops when we stop doing the rehab. And so it is about grit and sticking with it and persistence and frequency. There isn't a vacation. So if we all wind up on the beach in Hawaii, we should be doing our stretches and our PT on the beach in Hawaii. There isn't time off from it. But as long as that keeps going, we're seeing improvements. However subtle or small in some kids, it's still there. So opening it up for discussion, questions, yeah.
So going back to the E-stim, we've encountered twice through denials of appeal because E-stim is not, there's no proven cure, nothing to fix AFM.
Right.
So we've been trying to find the right wording. Can you help in any way with how to get an insurance company to understand that we're trying to preserve muscle mass until we figure out it's a single limb, single arm, which we have a PT friend who happened to find an E-stim that found its way to our house.
These things happen.
But yeah, these things happen. But to your point, we're not utilizing it the way it probably could and should be for its fullest effect. But our insurance has been, it's just there's no cure.
You can say it nicely.
Yeah.
And currently, the insurance stuff says it has to be requirement number one. You have to have the only thing you can order an E-stim for is building muscle mass or pain. So sometimes we can get around it if somebody has pain, because you can't use it for pain. So if you get the right.
Well, and our neurologist will write whatever we want. She's been trying to write, and it just keeps.
I had one case where when I used the diagnosis for, I used a general term, spinal cord injury. There's one that says traumatic spinal cord injury, and there's another that leaves off the word traumatic. It just says spinal cord injury. And that worked for one situation where this is a spinal cord injury. It happened to be a virus in the immune system, but it's a spinal cord injury. And for whatever reason, that coding worked.
So one other thing that you can try is if you can demonstrate a muscle contraction, this far above the injury so the therapist is in line. Because sometimes, it's not the whole